Assalamu alaikum. Dear students and colleagues, I will start to discuss with you some important points about the classification of gingival diseases. First of all, we will start with dental biofilm induced gingivitis or dental plaque-induced gingivitis. It can be defined as an inflammatory response resulting from interaction between the dental plaque and gingival tissue, remain contained in the gingiva and not exceed the mucogingival junction, and it is reversible by reducing the dental plaque at and apical to the gingival margin. Gingival inflammation can be on the gingival tissue called gingivitis. Gingivitis can be divided into a localized and generalized based on bleeding on propping percentage, and we previously discussed what is the meaning of bleeding on propping percentage. As we pass the probe inside the gingival sulcus gently with a controlled force and waiting. If there is a bleeding, give it score 1, or if there is no bleeding, give it score 0. And when the percentage of bleeding on propping ranging between more than 10% or and less than or equal than 30%, we will call it localized gingivitis, while generalized gingivitis defined as a patient presenting with bleeding on propping score more than 30%. Depending on whether gingival inflammation occurred on intact periodontium or in reduced periodontium, a gingival inflammation can be further classified into gingivitis occur on intact periodontium, mean that supporting apparatus of a teeth not affected by inflammatory response previously. All gingivitis or reduced periodontium in non-periodontitis patient, that is mean the destruction in the gingival inflammation in the supporting apparatus occur as a result of recession due to faulty toothbrushing or as a result of a crown lengthening procedure or orthodontic treatment. Also, we may have a gingival inflammation on reduced periodontium in successfully treated periodontitis patient, as we call it remission periodontitis. The gingivitis on intact periodontium can be characterized by inflammation associated with patient symptom. Also, there is bleeding on propping percentage more than 10%. Also, there will be associated with the propping pocket depth equal or less than 3 mm, assuming no attachment loss, no pseudo pocket, and no radiological bone loss. So, if we want to make a difference between gingivitis and clinical healthy gingiva on intact periodontium, we will see that there is only a difference in a bleeding on propping percentage, as the health associated with less than 10%, while gingival inflammation or gingivitis associated with bleeding on propping equal or more than 10%. The rest parameter remain the same. Secondly, we have gingivitis or reduced periodontium in non-periodontitis patient, such as patient have a gingival recession due to faulty toothbrushing or after orthodontic treatment. And in all these conditions, we will have a propping attachment loss, surely, and possibly we may have a radiological bone loss, while the propping pocket depth should not exceed or equal to 3 mm with a bleeding on propping more than 10%. While gingival inflammation or reduced periodontium in a successfully treated periodontitis patient will include the following symptoms, as the patient will surely have a propping attachment loss and radiological bone loss, while the bleeding on propping percentage is the same as the rest of gingival inflammation and should be equal or more than 10% with a propping pocket depth equal or less than 4 mm. Also, biofilm induced gingival inflammation can be furtherly classified according to the factor, local or systemic, or hormones associated with them. First of all, may be associated with bacterial dental biofilm only. That is mean the bacteria that found in the dental plaque only responsible for the initiation of the gingival inflammation. Second, potential modifying factor of plaque-induced gingivitis. From the name of Part B mean that there is a modification occur on the dental plaque by the presence of other factors that will exaggerate the inflammatory response, such as systemic condition like steroid hormone or hyperglycemia or leukemia, smoking, malnutrition. Also, we will have an oral factor enhancing plaque accumulation, such as a prominent subgingival restoration, orthodontic appliance, a prosthetic appliance, or hyposalivation. And lastly, we will have a drug-influenced gingival enlargement. First, we will start with associated with dental biofilm-induced gingivitis. Before we start to discuss all types of gingival inflammation, I would like to give you some common characteristic of all gingival disease that is associated specifically with dental plaque-induced gingivitis. You know, we call it dental biofilm or dental plaque-induced gingivitis. Why? Because it is associated with the presence of dental plaque, whether by itself or by the presence of modifying factor. And when we control or modify this plaque or this biofilm, the condition is reversible and the gingival tissue will return into its normal condition. And the most important characteristic that are found in the gingivitis is, first of all, it is a clinical diagnosis by itself. Until now, although the emerging technology, including all our life and medical field, but till now no specific laboratory examination could be sufficient for diagnosis of gingival inflammation. The other sign may be associated with gingival inflammation, including erythema, edema, pain, heat, and loss of function. Also, there is a swelling, loss of knife edge, margin, and blunting papillae. Sometimes we may have a patient symptom that have a bleeding on bleeding gum, also discomfort, or may have a metallic taste, pain, halitosis, and difficulty of eating or appearance. Radiograph cannot be used as a diagnosis for gingivitis since it includes the soft tissue only, also reversibility of disease by removing the etiology. Gingival disease. Gingival disease associated by dental biofilm only include plaque-induced gingivitis or dental biofilm-induced gingivitis. It is inflammation of gingiva resulting from dental biofilm. Second, gingival disease that is mediated by systemic or local risk factor. From the name, include systemic or local risk factor. The systemic factor include sex and steroid hormone, and the sex and steroid hormone include puberty or menstrual cycle or a pregnancy or oral contraceptive. And in all these conditions, there is exaggerated inflammatory response to the presence of even a small amount of dental plaque due to hormonal disturbance, either during puberty for a period from 11 to 16 years old, or during menstrual cycle, during ovulation, or in pregnancy during a pregnancy period. And there may be association with a tumor that is a painless protuberant exophytic gingival mass located mostly in the anterior region and develop in the first trimester. Many cases may regress or completely disappear following delivery. Also, we may have a hyperglycemia or leukemia. The hyperglycemia inflammatory response to dental plaque due to high sugar in the plasma of hyperglycemic patient, while leukemia associated with a pronounced inflammatory response of the gingiva to the dental plaque resulting from bleeding and enlargement subsequently to leukemia. The gingival bleeding is a common sign in patients who are leukemic and initial oral sign and symptom, in many cases acute or chronic leukemia. Also, we may have gingivitis associated with smoking, and it is considered as a major lifestyle risk factor for development of gingival inflammation and subsequently periodontitis. But due to vasoconstriction and fibrosis, this can mask the clinical gingivitis, and bleeding on probing may be not detected easily. In addition to that, we may have gingival disease modified by malnutrition. It is well known that malnourished individuals have compromised immune response, and many infections may develop due to malnutrition, and periodontal infection are one of these diseases associated with malnutrition. The gingiva may be bright, red, swollen, ulcerated, and susceptible to hemorrhage. And one of the most important nutrients that associated with gingival inflammation when it is deficient is ascorbic acid deficiency. To the second part of local and risk factor associated with gingival inflammation, which is local contributing factor, and that include the gingival inflammation due to a prominent prosthetic appliance or subgingival restoration, defective filling, and orthodontic appliance, while hyposalivation and redness and oral dryness is a clinical condition associated with some disease or intake of some drug that lead to low the cleansing action of saliva on the gingival tissue and exaggerate the inflammatory response due to change in the oral microflora. The drug that influence gingival disease, 3 drugs, including cyclosporine associated with kidney transplant or organ transplant as immunosuppressant, nifedipine associated with epileptic patient, and also calcium channel blocker. This drug may cause gingival overgrowth, and the common clinical characteristic associated with it may be a difference or variation in interpatient and intrapatient pattern. So we will have a genetic predisposing factor. Also, a predilection for anterior region and high prevalence in children and younger age group occur after onset of 3 months and change in the gingival contour leading to modification of gingival disease. Enlargement first observed in the interdental papillae, then there will be a change in the color of the gingiva and increase in the gingival exudate and bleeding upon propagation and pronounced inflammatory response. And I would like to add an important comment for this condition all that including a plaque only or local or systemic factor causing gingival inflammation or drug influenced gingival disease. All these disease, the most and important essential factor for associated with its cause is dental plaque or dental biofilm, and when we remove the essential factor, the condition is reversible and return to a clinical healthy